الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد أحد. بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد أحد. اللهم صل على سيدنا مولانا محمد وعلى آله वसहबिहि वबारिक वसल्लम। या अल्लाह, हमने जो ये आयत पढ़ी हैं और जो नजराना पेश किया है, इसका सवाब मरहूम प्रोफेसर मलिक हुसैन मुबशर साहब की रूह को पहुंचा दे और उनको जन्नत में आला से आला मकाम अता फरमा और उनके दर्जात को बुलंद फरमा और
हमें उनके नक्शे कदम पर चलने की तौफीक अता फरमा। हमें भी उतने ही बड़े और अच्छे काम करने की तौफीक अता फरमा जितने के उन्हें प्रोफेसर मुबशर साहब ने किए। Okay, so as requested, today's topic I want to present is antipsychotics or the treatment of schizophrenia. Unfortunately, again, as I was mentioning to you earlier, I was not able to prepare it too well, but still, whatever I was able to make the slides and do the things, I will be presenting them. So the topic is a huge topic. It's a big topic. It cannot be covered in a single sitting, but I will try to go through the basic concepts of management of schizophrenia, why the people don't respond to the treatment, and what we should be doing to make sure that the things are corrected. So schizophrenia is said to be the bread and butter of psychiatry. The reason being that it's a kind of an illness which lasts for long period of time. And even when the patients are okay and they are managed well and they respond to the treatment, again, they still need the follow-ups. They still need the, again, management and assessment strategies to be continued for life. It is just like diabetes, hypertension, and any other illness which goes on for a long period of time and needs to be monitored and corrected. So to start with, I will just start from here. The basic strategy in psychiatry, whenever we want to make sure that the people are okay, the idea is that we should be doing something like this. So if we just want to treat schizophrenia, or as a matter of fact, any psychiatric morbidity, it's not the receptor occupancy which is desired. The desire is to make sure that a receptor affinity is achieved and patient is well, healthy, comfortable, and back to normalcy. Now, this is what we have to acquire. If we talk in general about the psychiatry, about the psychotropics or antipsychotics, it's a very complex situation. How we give treatment to the patient is complex as well. Most of the time, I always repeated this and I always say this: if your diagnosis is appropriate, you'll be able to get the good outcome. But if your diagnosis is not appropriate, then definitely there will be few things which will be still there and you won't be able to bring back the patient to normalcy. The target is to bring the patients back to normalcy. Normalcy includes socially, he should be adjusted well, he should be doing a job, eating well, sleeping well, no symptoms at all, and a baseline level of any other normal, healthy individual. That is the target. And if we are not able to achieve it, then this means that there are complications associated with it. So what are the complications? Of course, we will in times, I will try to explain it to you as well. Now, you just have to imagine, before I start saying anything, before I go through my slides, that our brain is like a computer and it's like the CPU, central processing unit of whole of the body. When the child is born, before that, when the child is in the mother's womb, there is a process of neurogenesis. So from one cell in embryo, the embryo is formulated, and then their process of meiosis, mitosis, and multiplication. This process continues till the time the cell differentiation starts taking place. And then from there, the cell differentiation, the basic cell unit, the gene or the genome or the DNA, multiplies and diversify into various kinds of cells. One of the cell is called the neuron. And these neurons, when they multiply, they migrate from one end to the upper end here. And then the process of migration and then multiplication and then refinement in their process is the key. So whole of this process of neurogenesis, and then cells, each neuron is supported by 9 glial cells. And the glial cells are also the cells. Neuron has the capability of excitability. One neuron is just like this, and it has an offshoots like this. So there are axons and dendrites. And whole of the neuron body is sealed by the glial cells. Now, these axons and the dendrites, they are connected with the other axons and the dendrites with a space that we call synapse. And in these synapses, the multiple neurotransmitters, the dopamine, the serotonin, the norepinephrine, and all these neurotransmitters, they make the flow of electrical current or the stimulus from one cell to another cell. And imagine that this electrical impulse is not traveling just through the wire. It's traveling through the wire and the space, then the wire and the space, and then it continues throughout the brain. So if we use our imagination, you can imagine that all of these processes of neurotransmission, of an electrical impulse going from one end of the brain to another and generating a response like interpretation and response in form of a behavior is controlled by them. These neurotransmitters, so giving you an example, that initially it was thought that the dopamine is one neurotransmitter, but now we know that there are multiple types of the dopamine. So if this is dopamine, dopamine D1 has a slight notch on one side. D2 has another notch, D3, D4, D5, D6, D7. So the basic molecule stays the same, the dopamine, but they are divided into subcategories because of the slight difference in the structure. And this dopamine neurotransmitter goes from one side to another side across the synapse, and then get attached to the receptors and produces some effect or some neurotransmission. Now, this electrochemical gradient and the neurotransmission system is complicated. It's not very simple. If something happens in one of the neurotransmitter, moving from one end of the brain to another end of the brain, then of course the nerve impulse will not be the same as it is normally in usual circumstances. And when this nerve impulse gets problematic, our behavior is the manifestation of it. So if I'm sitting comfortably and I am happy, the player centers in the brain, the neurotransmitters in the brain, which affects the playerable activity, which is dopamine as well, is having a normal transmission. So I hear a good news, I feel player, and I'm happy. and the neurotransmission is appropriate. If I get a bad news, I'm upset, that center is suppressed and I feel sad, and this is because of the neurotransmission. If I'm sitting all by myself, alone, and there is no stimulus around me, and I'm not thinking about anything as well, but I start laughing by myself without the pleasurable effect, without the pleasurable stimulus, without a good something happening in my life, without thinking of something good in my life, I'm still happy without any reason, then this is self-smiling, which is a symptom of schizophrenia. And it is because of the distortion of this neurotransmission that I feel happy when there is no stimulus, when there is no thought, when there is nothing like that. And this is self-smiling, which is very much present and seen in schizophrenia. So any symptom which is abnormal is considered to be abnormal or a symptom of a disease because of the fact that it is not correlating with the situation, it is not correlating with the circumstances, and it is considered to be abnormal because statistically it is unusual. Now, I won't go into the detail of the definition of abnormal and normal, but just imagine that I am sitting here with you people and talking to you, so I am giving you some emotional responses. My facial expressions, the way I talk, the movement and the tone in my and the rhythm in my speech, it has some background. If I'm talking in a flat tone, no emotions, nothing, absolutely emotionless face and talking, then there is some problem in the emotional sensitivity or expression, which is controlled by the neurotransmission system, the dopamine and serotonin. So that abnormality needs to be treated with a specific treatment for a very specific neurotransmitter to correct that abnormality. If we are able to hit it, then we are good and the patients go back to normalcy. If we are not able to click it, then we are not, unfortunately, making the symptoms go away. Now, there is another problem, unfortunately, that there is no specific test, some significant investigative process, which is available to us where we can say, okay, fine, this test is abnormal, just like in diabetes, you go for an HbA1c, and if it is more than 6, the patient is diabetic, and you give the medication and make sure the HbA1c, even if it is 7, 8, 9, 10, it should brought back to level of 6 and less. So the diabetes is controlled. But what happens if I am not able to get an investigation and I'm treating the symptoms when I'm talking to the person and giving medicines according to that? That complicates the situation. So I need to have a very specific target symptomatology related to the target neurotransmission system and give a specific drug to correct that neurotransmission system to correct the psychosis or the symptom. Now, this is something very tricky, and this is a big job for a psychiatrist to do. So in nutshell, when I'm talking about the antipsychotics, there is a whole range of antipsychotics available. Previously, back in 30s and 40s, the only treatment available for schizophrenia or psychosis-like disorders was ECT. So anybody who was having these kind of symptoms was given ECT. Later on, there were some anesthetics available. So barbiturates, thiopentone, sodium, and other drugs which were available. And then they started coming into the practice. So whatever the patient was having psychosis, they were anesthetized to control the symptoms. But again, it was not a specific treatment. It was back in 1950s that the first antipsychotic, the chlorpromazine, came into being. So it was incidentally found that this drug was helpful in controlling the psychosis in 50s. Chlorpromazine is unfortunately not available in Pakistan or majority of the countries across the globe, but it was the drug which was used till 2000s, so almost 50 years, and it was used very frequently to treat psychosis. People loved it because it was the drug which was able to control the symptoms very well. Even John Nash, the character in The Beautiful Mind, who was a Nobel Prize winner, was on 350 to 400 milligrams of chlorpromazine, and he won a Nobel Prize. So you can very well imagine how good breakthrough was achieved by this chlorpromazine. After that, there was a range of antipsychotics which were available in the market. So the haloperidol, flupentixol, loxapine, thyroidazine, flufenazine, perfenazine, all of these drugs came into the market. Then there was some more modification, flupentixol, zuclopentixol. These drugs were launched as well. And in 80s, whole range of atypical neuroleptics were launched. Starting from risperidone, a new concept in the treatment of schizophrenia was launched, which was called serotonin dopamine antagonist, SDA concept. Now, risperidone was launched on the basis of SDA concept. So not only dopamine, but other neurotransmitter was included in the causation of the symptoms, and it was said that these symptoms can be corrected well with the drugs like risperidone, SDA concept. Exam question, what is SDA concept? How risperidone was launched? Exam question. In SDA concept, what other medications can help? What other medications are acting on the same principles? So these are some of the exam questions. And then after risperidone, there was olanzapine, then quetiapine, then ziprasidone, aripiprazole, brexpiprazole, isonepine, loracidone, iloperidone, paliperidone, and there are a few more which I was not able to mention them here. There are a few more drugs available as well. Now, on the basis of the history of antipsychotics, it was often based on chance findings that bear little relationship to intellectual background driving observation. So in 1891, Paul Ehrlich observed that anti-malarial effects of methylene blue, a phenothiazine derivative, worked well. Now, this methylene blue, which is a phenothiazine derivative, is the precursor of chlorpromazine and some of the other antipsychotics. Later, the phenothiazines were developed for their antihistaminergic properties. So phenothiazine, still we give promethazine as an antihistamine to control the allergic reaction. But then it was launched as an anti-allergic, but when it was given in a proper dose or the high dose, it was seen that it was helping as an antipsychotic in treating the psychosis. So in 1951, Lebroy and Huguenard administered the aliphatic phenothiazine, chlorpromazine, to patients for its potential anesthetic effects during surgery. Thereafter, Hammond et al. And DeLay et al. Extended the use of the treatment in psychiatric patients and serendipitously uncovered its antipsychotic activity. So it was occupying the dopamine receptors and it was correcting the psychosis. So it was a breakthrough in the treatment of schizophrenia. And between 1954 and 75, about 15 antipsychotic drugs were introduced in the US alone and about 40 throughout the world. So not all the medications are generated in the US. There were few other drugs which are like the zuclopentixol and flupentixol. They were made by Danish company. So there was research going on across the globe, and they used the same principle that this drug is affecting some of the neurotransmitter system. Previously, it was hypothetical, and then later on, when more studies were available to see the metabolites of the these neurotransmitters and see the receptor occupancy in the brain and the metabolism of the drug in the brain, then it was more clear about their mechanism of action. So even when they were launched, the mechanism of action of these drugs was not very clear, and it became clear much after that. So the drugs which are launched now, they are much better form because now we have more investigations to see the metabolism. Same goes for like the COVID. Now, a vaccine development for any viral infection takes about 10 years. But in case of COVID, they have developed the vaccine in few months. And the only background is that there were vaccines available in the market, they were modified, corrected, and we made sure that this may be helpful in treating the COVID. So it was easy. So thereafter, there was a hiatus in the development of antipsychotic until the introduction of clozapine treatment in the US, which opened the era of atypical antipsychotic. I think this date is not appropriate. It was more like 1970s when the clozapine was launched, and later on the clozapine was extended. So coming back again, there are few terms which are confusing for most of the residents, even for me now. So why we use the term atypical antipsychotic, why we use the term second generation antipsychotic, why we use the term dopamine partial agonist, why we use the term third generation antipsychotic or next generation antipsychotic. Now there are few big bodies in psychiatry which probably coin these terms and throw them in their literature, and then these terms are opted and adopted by the psychiatrists across the globe, like APA, like WPA, like European Psychiatric Association. So there are big psychiatric, again, bodies which usually throw these terms. So the classic and commonly used terms, the neuroleptics. Now, neuroleptics or major tranquilizer was the name given to most of these drugs. And the reason was because they were used as an anesthetic initially. And then their major side effect was sedation. So they were called major tranquilizers or neuroleptics. But later on, they found that this is not just the only action they have. They have other properties. So let's change the name. So they were given the name of typical antipsychotics. And then the typical name was again very odd. So WPA proposed the name first generation antipsychotics. So all the three names, major tranquilizers, neuroleptics, typical antipsychotics, or first generation antipsychotic is the same, except the different bodies and different authorities gave it a different name. Similarly, when new drugs with the SDA concept was launched, risperidone or clozapine, the name atypical antipsychotic was launched. And the reason why it was given the name atypical was that it was not affecting only the dopamine receptors. So they have other properties which gave them the name of atypical. And then it was thought that this name is not enough to give a good description. So the name second generation antipsychotic was used for them. Then there was other drugs which were probably acting more on other neurotransmitters. So there was a glutamate concept of schizophrenia, and there was a concept of involving other neurotransmission system as well. So this name, the atypical antipsychotic, was not sufficient. So there came the name dopamine partial agonists. And these drugs were called third generation antipsychotics. Now there are drugs which affect on multiple focused receptors, treating the schizophrenia very specifically. Not like chlorpromazine was affecting histaminergic receptors as well, serotonergic as well, but they were broad. Now there is a focus on only the neurotransmitters responsible for causation of schizophrenia, those needs to be targeted. So more targeted drugs on multi-receptor modulation, and they are called the next generation antipsychotic. So first generation, second generation, third generation, and the next generation are names given over the period of time to these drugs. Now, why the typical drug was used, antipsychotic name was used? Because these drugs were affecting dopamine receptors. Two, these drugs were causing extrapyramidal side effects, including dystonia, Parkinsonism-like symptoms, tremors, and the most worst component was that they were producing tardive dyskinesia. Now, tardive dyskinesia is an irreversible side effect of an antipsychotic. So once a person develops TD, then it cannot be cured with any drug. And it is, again, I'm not going into the details of what causes that tardive dyskinesia, but tardive dyskinesia itself is an abnormal movement disorder, which is unfortunately irreversible once the changes in this system are made permanent. It is not dose related. It is not, unfortunately, because of the long-term use. Some people develop it in a short period of time. Some people develop it in a long period of time. Some people develop it in a low dose. Some people develop it in a high dose. So the ideal situation is that we should try to make sure that people should not develop tardive dyskinesia. So initial assessment to rule out this extrapyramidal side effect is important. So the typical antipsychotics were affecting the dopaminergic system. They were producing the extrapyramidal side effects, and they were causing sedation as well. These were major side effects, major problems associated with them. These were the drugs called typical. Now, atypical drugs, when the SDA concept came in, they have spectrum of action. So they were trying to address the negative symptoms of schizophrenia as well. And they were trying to address the affective component in schizophrenia as well. So the mood symptoms, the affective component, and again, addressing the cognitive functioning in schizophrenia, which was getting compromised with the typical neuroleptics, and better efficacy in terms of treating the positive symptoms. So atypical neuroleptic was name given. High ratio of serotonin, dopamine receptor blockade appear more specific for mesolimbic than striatal dopamine system, and different side effect profile and low risk of EPS. So there are some atypical antipsychotics like risperidone, lurasidone, which can cause extrapyramidal side effect, but to a lesser degree and lesser problematic situation. Now, these side effect profile and the safety profile, when it is improved, because they are specifically targeting the specific neurotransmitter areas which is causing the schizophrenia or psychosis and not causing the side effect as a whole in the brain. So when a drug which is just affecting the dopaminergic system will affect the dopaminergic across the body. But when it is targeted, that this dopaminergic drug will be addressing specific areas in the brain, it is an atypical antipsychotic, which has a specific targeted drugs. This is what we are trying to achieve. Now, these are some of the drugs which we called atypical antipsychotics drugs, like olanzapine, like Seroquel, quetiapine, Abilify, which is aripiprazole, risperidone. And I mentioned you earlier some more names as well. So those names are important. Going back to the etiology of schizophrenia. Now, why we are interested in knowing the etiology, why we are interested in knowing the cause, a specific area of the brain which is having abnormality, which is causing those self-talking, self-smiling symptoms, or paranoid symptoms, or grandiose symptoms, or any other symptom of schizophrenia and psychosis. If we know that specific point, we'll be able to touch that specific point and the patient will be okay. But if we'll be just hitting the ball, like most of the people we do, patient आया उसको देखा and then we just try to evaluate the patient and then we saw the patient, we thought, oh, this is schizophrenia, let's try one drug. We have given one drug and then later on found that this drug is not helping, let's change it. Give him 2, give him 3, give him 4, give him 5, and then things don't work like this. This is the key message for today's presentation. Whenever you are treating psychosis, be very specific for the treatment. And the treatment is not only the drug you are choosing for the client, it is also the dosage. Now, people do give risperidone 1 milligram per day. Now, there are no studies which can prove to me that 1 milligram of risperidone can occupy the receptor 80% and correct the psychosis. Most of the studies show that we have to give the medication in a therapeutic dosage, and the therapeutic dose range is specified for every drug. If you won't follow the therapeutic range, patients won't get better. So if the risperidone is given, the dose range is between 2 to 6 milligrams per day, where the 80% receptor occupancy is achieved and patients do get better. If it will be less than that, it will be of no use. Same goes for aripiprazole. 5 milligram of aripiprazole won't do anything. The therapeutic dose range of aripiprazole to have its effect in the books is about 10 to 30 milligrams per day. Excuse me. So unless or until we'll be able to give the dosage in a therapeutic range, we won't be able to address the symptoms. So make sure that when you prescribe a drug, you should know 5 basic things about the drug. 1, the efficacy of the drug. 2, the safety profile of the drug. 3, the side effect of the drug. 4, the half-life of the drug. And lastly, and most importantly, the therapeutic range of the drug. If you know these parameters, then it's easy. If a patient walks into my clinic and when he starts walking inside the door, I start observing the patient. And the moment the patient enters, I know that this person is having this side effect of the drug. I don't have to touch him to know this. Most of the time, the observation, if you know the side effect, is enough. You touch the patient only after taking the consent from the patient and examining him. Yes, we do need to do the examination as well to reconfirm our findings. But seeing is important. Observation is important. If you will not observe the patients, you will not be able to understand what side effect profile they are having and how they should be addressed and what should be done about it. So aripiprazole can cause akathisia. Now, akathisia is just a subjective restlessness. It is not actually, you cannot examine akathisia. You have to see and observe the patient to assess it and ask specific questions about it. Since the time I have started taking the medication, I don't know, there is something in my legs. I cannot sit still. I cannot sit static. I am not able to stand at one point. I keep on moving my legs to make myself comfortable. This is akathisia. And you have to assess the side effect and you will know that this is a side effect. So either the drug dosage needs to be reduced or it needs to be changed. That is the decision that you have to take on the basis of the clinical assessment. So for us, I'm sorry, I was detracked, but for us to understand the etiology is not to read the etiology as a bookish knowledge. It is to implement this etiological principles into clinical practice. And if we are not able to do that, we won't be able to treat the patient. Now, etiologies, whenever we want to talk about etiology, the basic etiology, this picture is in front of you and you can see what is there. Mesocortical dopamine pathways. basal ganglia, nigrostriatal dopamine pathways, mesolimbic, mesocortical, and nigrostriatal. Now we know that a typical dopaminergic pathways are these three: nigrostriatal, mesolimbic, mesocortical, and basal ganglia. Now, these pathways, so whatever drug I want to use, it has to be very specific dopaminergic drug, which will just affect the mesolimbic dopamine pathways, and the psychosis will be okay. If it is addressing the mesocortical, there will be some more things into it. And if it goes to nigrostriatal, then of course there will be hordes of side effects. Now this is tricky. So, and tuberoinfundibular, another pathway, so which is dopaminergic as well. So prolactin levels is usually high because of this pathway. So we don't want the other pathways to be filled up and giving the side effects to the patient. So I want a very specific drugs which can address the emotional component only, correct the delusions and hallucinations, and won't produce any side effect. This is the specificity of the antipsychotic, and this is the etiology behind it. If we know the etiology, we'll be able to treat it properly. So the dopamine pathways, the tuberoinfundibular, hypothalamus to pituitary, hormonal regulation, maternal behavior, nurturing, pregnancy, sensory processes. Now, if the patient is having psychosis, I don't want to address this. Mesolimbic and neocortical pathways, ventral tegmental area to nucleus accumbens, amygdala, and hippocampus, and prefrontal cortex. Now, if you see these areas of the brain, they are related to emotions and the memory, so the cognition, the negative symptoms, and I hope I'm still there, yes, and emotions, cognitions, and positive symptoms are all here. So I just want to address this. I don't want to address the other pathway system. Nigrostriatal, substantia nigra to striatum, motor control. Death of neurons in the pathway can result in Parkinson's disease. This is the cause of extrapyramidal side effect, and I don't want to have it. So I will try to formulate a drug which won't affect nigrostriatal or tuberoinfundibular pathway. I want a drug which is very specific, which can affect the mesocortical or mesolimbic pathways, specifically mesolimbic, even not mesocortical. So this etiology is important for me to know and to understand. So the dopamine hypothesis says the schizophrenia results from excessive activity of dopamine neurotransmission in mesolimbic and mesocortical pathways because all antipsychotic drugs block dopamine receptors. Stimulant drugs which act through dopamine can produce schizophrenia-like behaviors, for example, amphetamine. And levodopa and dopamine precursor can exacerbate schizophrenia symptoms or occasionally elicit them in non-schizophrenia patients. Higher levels of dopamine receptors measured in the brains of schizophrenia by PET scan. So brain increase during psychotic episodes, the brain dopamine increase during the psychotic episodes, but not during remission. So if the person is okay, he goes into the remission, the dopamine increase goes back to normal. And if it is normal, the person is fine. So if a patient comes to me and he gives me some symptoms which I believe are related to just the dopamine system, the best drug to be chosen is something which will be affecting the dopamine system. And if I believe that this patient is presenting with the symptoms of the dopaminergic system and serotonergic system, then the best drug will be STA drug. Now, if I believe that the patient is presenting to me with some glutaminergic pathways as well, symptoms of glutaminergic pathways, then the best drug will be some newer generation antipsychotic. This is tricky. So all patients don't need the same antipsychotic. So जो आ रहा है उसको रिस्पेरिडॉन 12 मिलीग्राम 6 मिलीग्राम 10 मिलीग्राम टिकाई जाओ khangi jao te langi jao. This is not psychiatry. If we have to practice psychiatry, we should be human first and don't consider our patients to be experimental guinea pigs. Don't experiment on them. So they are humans, just like you and me, and we have to treat them properly. So listen to your patient carefully. Listen to the symptoms carefully and correlate these symptoms with the pathways associated in the brains. If you know those pathways, if you know the symptoms produced by them, you'll be able to treat them properly. If you don't know the pathways, ਤੁਸੀਂ ਬਸ ਗੂਗਲੀਆਂ ਕਰਾਓਗੇ ਤੇ ਹੁੱਕਾ ਮਾਰੋਗੇ, things won't get better. So to get it better, you have to be very specific. And if you are specific, the patients get well. If you are not specific, you are just seeing the patient, making a diagnosis and giving something, patient won't be okay. So I have to listen to the patient, correlate the symptoms with the pathways, and then come up with a drug, give him this. This will work for him. And of course, it's not something very confirmed because there is no diagnostic test, because it's just my feelings and perception and assessment. I may be wrong, but in majority of the situation, it works. In some of the people, it won't work. We will come up to that point, and I will explain it to you, the resistant schizophrenia as well, where this is the problem. So the role of dopamine in schizophrenia is quite complex. Positive symptoms are thought to be a result of overactivity in mesolimbic pathways, activating D2 receptors, while negative symptoms may result from a decreased activity in mesocortical pathways, which is a dopamine D1 receptors. And nigrostriatal and tuberoinfundibular pathways appear to be normal in schizophrenia, so I don't want to touch them. So this is important for me. If I have to address the negative symptoms, apathy, alogia, lack of emotions, blunting, in lack of initiation, then I will go for some drug which will be acting on mesocortical dopamine D1 pathways. And if I want to address the positive symptoms, overactivity, hyperactivity, aggression, I will go for some drug which will do the D2 effect. And this is the rationale of choosing the antipsychotic. So the basic theme, I am not sure I have completed this or not. So I thought that I just made 10 or 12 slides. So I'll be just wrapping it up. We'll pick it up from here to next time, inshallah. So the glutamate hypothesis, the glutamate excitatory neurotransmitter, the neurotransmitters which are affecting, there are two stimulating neurotransmitter, excitatory neurotransmitters, rather to be very specific, and the rest are other neurotransmitters. Glutamate and GABA are excitatory. Now, glutamate system, NMDA receptors, inotropic glutamate receptors. It is observed that NMDA hypofunction on one hand, decrease dopamine in mesocortical pathway, so increase negative symptoms. Now again, if I perceive that these negative symptoms are secondary to the excitatory neurotransmitters in the brain, not the dopaminergic system in the brain, I will go for some glutaminergic drug which can address the glutaminergic system, which in sense will balance the dopaminergic system and correct the negative symptoms, and patient will be okay. So I will not choose a drug which is addressing the dopaminergic system, because dopaminergic system is affected secondarily, not primarily. So in primary situation, I will address the glutaminergic receptors. And on the other hand, increase in dopamine in mesolimbic pathway, hence increased positive symptoms. Evidence NMDA receptor antagonist, phencyclidine, ketamine. Now these days, ketamine is used to treat major depressive disorder resistant to pharmacological treatment. So you give ketamine to patients and their depression goes away, which again addresses positive and negative psychotic symptoms as well. So in nutshell, to understand which drug to be given to which patient and how, I need to know the symptoms, correlate them with the etiological neurotransmission system, choose a drug specific to it, and patient will be okay. Otherwise, you will keep on barging here and there, and patient will be a resistant case and unfortunately not respond. Okay, yes, so one more slide to go. Serotonergic pathways. Many effective antipsychotic drugs, in addition to blocking dopamine receptors, also act as serotonin receptor antagonist. Many atypical antipsychotic drugs produce fewer extrapyramidal side effects than dopamine selective compounds, as they also combine with serotonin receptors. I hope I'm still there. Okay, yes, I am. Whether serotonin receptor blockade accounts directly for their antipsychotic effects or merely reduces undesirable side effect associated with dopamine D2 receptor antagonists remains controversial. But still, there is one way of looking at the things and addressing them. Okay, so this was the presentation for today. Any questions or any comments? I'm open to it. जी, कोई सवाल ये सब समझ आ गई?
जी सर।
वालेकुम अस्सलाम जी।
सर बहुत सारी चीजें क्लियर हो गई, बस मुझे एक एग्जाम ओरिएंटेड चीज पूछनी है कि अगर हमसे किसी भी ड्रग का एंटीसाइकोटिक्स का फॉर से मोड ऑफ एक्शन पूछा जाता है तो हम उसमें हाइपोथेसिस भी लिखेंगे और रिसेप्टर्स को भी डिफाइन करेंगे और किस एक्सटेंट तक हमें डिटेल लिखनी होगी?
नहीं, ये एग्जाम क्वेश्चन का आंसर नहीं है। एग्जाम में जब क्वेश्चन स्पेसिफिकली आता है कि रिस्पेरिडोन का मोड ऑफ एक्शन बताइए, तो आपको रिस्पेरिडोन का स्पेसिफिकली मोड ऑफ एक्शन बताना है। आपको ये कॉन्सेप्ट्स अगर क्लियर होंगे तो एसडीए कॉन्सेप्ट क्लियर होगा। एसडीए कॉन्सेप्ट में पढ़ाऊंगा डेफिनेटली। एसडीए कॉन्सेप्ट जब क्लियर होगा तो आप रिस्पेरिडोन का मोड ऑफ एक्शन सी आराम से लिख देंगे, लेकिन वो स्पेसिफिक होगा, रिस्पेरिडोन का एसडीए कॉन्सेप्ट होगा और उस ड्रग से रिलेटेड होगा। अगर वो मोड ऑफ एक्शन पूछते हैं एसिनापेन का, तो वो एक अलग मोड ऑफ एक्शन है, ठीक है। अगर वो मोड ऑफ एक्शन पूछते हैं हेलोपेरिडोल का, तो वो डोपामिनर्जिक है, तो उसमें आप डोपामिनर्जिक कॉन्सेप्ट लिखेंगे। लेकिन अगर वो पूछते हैं ओलेंजापीन का, तो उसमें हिस्टामिनर्जिक भी आ जाता है, सो उसका आपको मिक्सचर में देना पड़ेगा। सो हर दवाई का मोड ऑफ एक्शन उसकी रिसेप्टर ऑक्यूपेंसी पे डिपेंडेंट है। ज्यादातर सारी दवाइयों के नहीं पूछे जाते, मोटी मोटी 4-5 दवाइयां हैं जिनके मोड ऑफ एक्शंस यूजुअली पूछे जाते हैं। टिपिकल एंटीसाइकोटिक्स का सारों का एक जैसा है। एटिपिकल्स में एसडीए कॉन्सेप्ट रिस्पेरिडोन का है। क्लोजापीन हैज अ डिफरेंट कॉन्सेप्ट, उसका पूछा जा सकता है। और बाकी न्यूअर जनरेशन एंटीसाइकोटिक्स का कुछ का अगर पूछा जाए, अनफॉर्चुनेटली तमाम न्यू जनरेशन एंटीसाइकोटिक ड्रग्स आर नॉट अवेलेबल इन पाकिस्तान। सो लोरासिडोन इज अवेलेबल, ब्रेक्सपेप्राजोल अभी वहां नहीं आई, एसिपिनम भी वहां नहीं आई, अभी आइलोपेरिडोन आई लेकिन इतनी पॉपुलर नहीं है, और पेलिपेरिडोन वहां पे अभी लॉन्च हुई है, मतलब से 1.5-2 साल से पेलिपेरिडोन आई एम राइटिंग इट इन पाकिस्तान, सो इट्स अवेलेबल। बट अगेन अभी वहां पे सारी दवाइयां एग्जिस्ट नहीं करती, मौजूद नहीं है मार्केट में, सो आप लोगों को एक्सपीरियंस भी नहीं होगा। लेकिन मोड ऑफ एक्शन आपको स्पेसिफिक दवाइयों का लिखना है। आपके साइकियाट्रिस्ट थ्योरेटिकली स्पीकिंग शायद एसिनापिन के बारे में पूछ लें, प्रैक्टिकली तो वहां पे साइकियाट्रिस्ट ने किसी ने एक्सपीरियंस नहीं की सेपरल, सो वो कैसे पूछ सकते हैं क्वेश्चन? आई डोंट थिंक सो, दे विल आस्क यू। सो जो 4 दवाइयां मेन वो पूछेंगे। जी 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 डॉक्टर।
एरिपेप आ चुका है, एरिपेप्राजोल का पूछा था, तो वो
बेटा एरिपेप्राजोल पुरानी दवाई है ना, अब साइकियाट्रिस्ट लिखते हैं उसको, ठीक है। सो इसका इसलिए वो पूछ भी सकते हैं। लेकिन ब्रेक्सपेप्राजोल पाकिस्तान में नहीं आई, सो उसका शायद वो ना पूछें। ब्रेक्सपेप्राजोल, अब हम एरिपेप्राजोल यहाँ पे नहीं लिखते, अब हम ब्रेक्सपेप्राजोल लिखते हैं, जो मॉडिफाइड वर्जन ऑफ एरिपेप्राजोल है, न्यू ड्रग। सो उसका कॉन्सेप्ट फर्क है। लेकिन जब मैं ये सारी चीजें पढ़ा दूंगा, सो वो कॉन्सेप्ट क्लियर हो जाएगा इंशाल्लाह, डोंट वरी अबाउट दैट।
ओके सर, थैंक यू।
You're welcome. Any other question? I'm sorry I haven't seen the chat box, but I will just try to look at it. But अगर अच्छा इसमें सिर्फ स्लाइड्स हैं, कोई क्वेश्चन है इससे रिलेटेड तो पूछ लें. मुझे नहीं पता ये टॉपिक आप में से कितने लोगों को इंटरेस्ट करेगा, लेकिन ये टॉपिक इम्पोर्टेंट है. मेरा ये ख्याल था कि ये वाले टॉपिक्स क्योंकि फार्मास्यूटिकल फोरम्स पे पाकिस्तान में कवर हो जाते हैं, सो मैं ना बोलूं, लेकिन मुझे फीडबैक से ये फीलिंग हुई कि ये इम्पोर्टेंट एरिया है, शुड नीड शुड. सो साइकोफार्माकोलॉजी is a huge concept, and unless or until you are expert in it, you cannot be a good psychiatrist. So make sure that you master in psychopharmacology. Or exam mein 40% questions are related to psychopharmacology, either antidepressant, antipsychotic, mood stabilizer, or whatever, but they are related to it. Treatment or management plans में the pharmacological treatment strategies हर इम्तिहान में पूछी जाती है, so वो भी important है, so उसको भी जानना जरूरी है, right? So any other comment?
सर आपने बताया कि टार्डिव डिस्काइनेसिस का ट्रीटमेंट नहीं होता, लेकिन लोअरिंग द डोज या विटामिन ई और टेट्राबेनाजीन बुक में मेंशन है, उनके बारे में आपके क्या कमेंट?
क्या रिपीट, कैन यू रिपीट द क्वेश्चन?
सर टार्डिव डिस्काइनेसिस आपने कहा दे आर नॉट ट्रीटेबल.
दे आर नॉट.
तो सर बुक में लिखा हुआ है कि विटामिन ई का रोल है, लेकिन कॉन्फ्लिक्टिंग है.
13 से 17 दवाइयों को कहा गया है कि they may help,
right.
but they are not the treatment. There is a difference in the treatment and help. So if a patient develops a tardive dyskinesia, unfortunately it's an irreversible process. There is no treatment for it. All the treatment which are available for tardive dyskinesia management, it's just again a trial. So कुछ लोगों को विटामिन ई से इम्प्रूवमेंट आ जाती है, कुछ लोगों को बीटा ब्लॉकर से इम्प्रूवमेंट आ जाती है, कुछ लोगों को लोअरिंग ऑफ द ड्रग से इम्प्रूवमेंट आ जाती है, कुछ लोगों को चेंजिंग द एंटीसाइकोटिक से इम्प्रूवमेंट आ जाती है. जहां कोई बात नहीं बनती वहां हम क्लोज़ापिन दे देते हैं, कुछ लोगों को उससे इम्प्रूवमेंट आ जाती है, बट इट्स नॉट नेसेसरी कि वो हेल्प करेगी.
Okay.
So it's not the treatment, it's just the help. Treatment साइकोसिस की है, टीडी की नहीं है.
Right.
अस्सलाम वालेकुम सर.
वालेकुम अस्सलाम.
सर आप अभी पहले एकथीजिया के बारे में बात कर रहे थे कि किस तरह एरिपिप्राजोल बहुत ज़्यादा एकथीजिया करवा सकती है और अक्सर करवाती भी है. तो अगर कोई पेशेंट हमें लगता है कि उसमें एरिपिप्राजोल का अच्छा रोल आ रहा है, लेकिन उसने स्टार्ट किया और उसको माइल्ड एकथीजिया हो रहा है, तो द ओनली ऑप्शन वी हैव कि हम उसको एरिपिप्राजोल स्टॉप कर दें, या कैन वी कंट्रोल द सिम्टम्स समहाउ?
एक चीज याद रखिएगा, ये पाकिस्तान में बड़ी कॉमन स्ट्रैटेजी है जो अब दुनिया में यूजुअली इस्तेमाल नहीं होती. ये स्ट्रैटेजी कि हम जब देखते हैं कि साइड इफेक्ट आ गए तो हम डोज वही रखते हैं, एंटीकोलिनर्जिक्स ऐड कर देते हैं. इट्स नॉट अ गुड स्ट्रैटेजी टू डू इट, राइट. एकथीजिया अगर एरिपिप्राजोल से डेवलप हो गया है और आप उसमें मेडिकेशन ऐड कर रहे हैं, लाइक एंटीकोलिनर्जिक ऐड कर रहे हैं या बीटा ब्लॉकर ऐड कर रहे हैं या और दवाइयां एंटी कन्वल्सेंट ऐड कर रहे हैं, वो शायद वक्ती तौर पे उसको सप्रेस कर दे, लेकिन एकथीजिया डिसअपीयर नहीं होगा क्योंकि वो न्यूरोट्रांसमीटर लेवल पे हो रहा है. अगेन पैथोलॉजी अंडरस्टैंड करें कि एरिपिप्राजोल उस शख्स के ब्रेन में जाके न्यूरोट्रांसमिशन सिस्टम को ऐसे हैंडल कर रही है कि नाइग्रोस्ट्राइटल पाथवे ज्यादा स्टिमुलेट हो गया और जो डोपामिनर्जिक पाथवे जिसको एड्रेस होना था वो नहीं, मीजोकॉर्टिकल पाथवे, मीजोलिम्बिक पाथवे वो स्टिमुलेट नहीं हुआ उतना कि साइकोसिस एड्रेस करता. हाँ, अगर आप फील करते हैं कि जी इक्वल हो गया, एकथीजिया भी डेवलप हो गया और उसका साइकोसिस भी ठीक हो गया, फिर एक मुश्किल सिचुएशन होगी. उसमें यू मे ट्राई एडिंग anticholinergic or a beta blocker or something like that, but in majority of the cases scientific evidence ये suggest करता है, जितने रिसर्च पेपर्स छपे हुए हैं, कि उसमें वो हेल्प ज्यादा नहीं होती. So changing is a better option unless or until कि पेशेंट बिल्कुल स्टेबल हो गया सिवाय एक साइड इफेक्ट के. जिसमें अगेन मैं फिर वही बात जो मैंने सबसे पहली तस्वीर दिखाई थी, हमारा मकसद पेशेंट को कंफर्टेबल करना है, उसकी क्वालिटी ऑफ लाइफ को इम्प्रूव करना है। अगर हम एक दवाई दे के उसकी क्वालिटी ऑफ लाइफ को कॉम्प्रोमाइज्ड ही रख रहे हैं, so there is no fun in doing that. Find another way. Unfortunately, this is what my concept is.
Thank you, sir. Thank you.
You're welcome. Any other question? Okay.
सर मेरा एक सवाल है कि ये ड्रग इंड्यूस्ड पार्किंसनिज्म होता है, समटाइम्स इट बिकम्स इरिवर्सिबल इन सम पेशेंट्स, तो उसमें न्यूरोलॉजिस्ट के साथ हमारी काफी समटाइम्स आर्गुमेंट्स होती हैं. we're trying to say it's Parkinson's disease, they are saying that it is drug induced. So ये drug induced Parkinsonism, ये why it becomes so irreversible at times, and what should be the solution for that?
मैं वो रखा हुआ था अपनी स्लाइड्स में, आगे इंशाल्लाह मैं बनाऊंगा उसके ऊपर स्लाइड्स, ये क्योंकि ये एक ट्रिकी सब्जेक्ट है और पाकिस्तान में भी ये बहुत ट्रिकी सब्जेक्ट है. एंड यू नो दिस कि यहाँ पे हम लोग बहुत पेशेंट्स को, हमारे पेशेंट्स में फॉलो अप एक कॉम्प्रोमाइज स्टेट में होता है. सो अब हमारे साथ होता ही है कि हमारे पेशेंट्स दवाई लेते हैं, चले जाते हैं, खाते रहते हैं, 6 महीने तक आए नहीं. वो जी कोरोना हो गया था, सो मैंने 6 महीने से दिखाया नहीं. अच्छा दवाई खा रहे थे, हाँ खा रहा था, तो भाई तुम्हें ये साइड इफेक्ट हो रहा था, तुमने बताया क्यों नहीं? ओ जी ऐसी सोचा जब जावांगे तो फिर पूछ लांगे. सो ये अनफॉर्चुनेटली प्रॉब्लमेटिक स्टेट है. तो पाकिस्तान में फिर एंटीकोलिनर्जिक्स का और इन ड्रग्स का इस्तेमाल बहुत ज्यादा है. पार्किंसनिज्म लाइक सिम्टम्स डेवलप होते हैं सुपर सेंसिटिविटी ऑफ डोपामिनर्जिक रिसेप्टर्स की वजह से, और उसके पीछे एक बहुत पैथोलॉजी है, वो इंशाल्लाह आई विल ट्राई टू एक्सप्लेन इन डिटेल. सो कामरान का क्वेश्चन मैंने रजिस्टर कर लिया, इसका जवाब मैं दूंगा डिटेल से.
Thank you, sir.
You're welcome. Thank you very much all of you for coming in. मेरे उस्ताद के लिए दुआ कीजिएगा, आप सब मिलके पढ़ सकें तो जरूर पढ़ें, फातिहा पढ़ें और कुरान पढ़ें, उनके ईसाले सवाब के लिए दुआ कीजिएगा. उस्तादों का साया, माँ बाप का साया हमारे सर पे सलामत रहे तो बेहतरी है. उस्ताद नहीं तो इंसान अंधा है इस दुनिया में. उस्तादों की इज्जत करें, उस्तादों का ख्याल करें. अल्लाह हमें उनके नक्शे कदम पर चलने की तौफीक अता फरमाए और हमें बेहतर साइकियाट्रिस्ट बनाए. तो आए अपना ख्याल रखिएगा. इंशाल्लाह फिर नेक्स्ट टाइम मुलाकात होगी. अल्लाह हाफिज.
थैंक यू.